This is slide number 54 of the chapter 18 PowerPoint slides. So regulating kidney function. For example, one example of regulating kidney function, when we talk about regulating kidney function, we mean regulating the glomerular filtration rate, so the rate at which the kidneys are filtering the blood. So in response to reduced blood flow to the kidney and decreased filtration rate, the afferent arteriole and glomerular capillaries are dilated. And then the efferent arteriole is constricted. And the combination of those things increases the glomerular blood pressure, which is going to raise the filtration rate back to normal. Now, if the blood pressure rises, the opposite occurs. Let's see. In response to increased blood pressure and blood flow and increased filtration rate, the afferent arteriole diameter reduces. So it instead of dilating and getting larger, it constricts. And that reduces blood flow into the glomerulus and decreases the filtration rate back to normal. So that's what we call, I guess you say, local control, local regulation, or auto-regulation, I'm sorry. Auto-regulation is when the blood flow and blood pressure is low and filtration rate is low, dilating the afferent arteriole and constricting the efferent arteriole will raise it. And then when blood pressure is too high and filtration rate is too high, of course, that can put too much work on the kidneys and cause kidney damage. So the afferent arteriole constricts. That reduces the flow into the glomerulus and decreases the filtration rate back to normal. So then there's hormonal control of kidney function. So hormonal control is always more long-term. The major hormones that can affect kidney function are angiotensin II, ADH or antidiuretic hormone, aldosterone, and ANP or atrial natriuretic peptide. Now, the angiotensin II is part of the renin-angiotensin-aldosterone system. So what happens is this. First you have, this is in response to low blood pressure or low blood volume, a drop in blood pressure or blood volume, okay? So that is going to cause activation of the renin-angiotensin system. Renin is going to activate angiotensinogen into angiotensin 1. And all of this is not highlighted because I would never ask you all this detail. I just want you to understand it's like starts with the release of renin. So you have low blood pressure. Renin is released from juxtaglomerular cells. And remember, those are the cells that are in contact with the DCT at the point where it comes up through in between the afferent and efferent arterioles. And I'll remind you about that in just a minute when I have a slide where I can show you a picture. But basically, renin is released from cells within the kidney itself, okay? And that is released in response to a drop in blood pressure or a drop in blood volume. Renin converts angiotensinogen into angiotensin 1, and then ACE converts angiotensin 1 into angiotensin 2. Bottom line is renin leads to the formation of angiotensin 2. Now, the action of angiotensin 2 is really what causes the change. Angiotensin 2 causes peripheral vasoconstriction, and that is just constriction of the blood vessels, constriction of your blood vessels, basically, in general. That is going to lead to increased blood pressure in the renal arteries, okay? Because it's going to constrict all of your muscular arteries. And so that will increase the blood pressure in the renal arteries as well as other arteries. Then constriction of the efferent arterioles will increase the filtration rate. Angiotensin 2 also leads to the secretion of aldosterone, epinephrine, and norepinephrine from the adrenal glands. That increases the reabsorption of sodium. And one of the things you always have to know in A&P is that water follows salt. So increasing sodium reabsorption will increase water reabsorption, which will lead to higher blood volume, which will lead to higher blood pressure. All right, then the other thing that angiotensin 2 causes is the release of ADH from the posterior pituitary gland. And ADH, high levels of ADH, lead to you conserving water and having a low volume of concentrated urine. And so it's all of these effects are to raise blood pressure and raise blood volume, which raising blood volume is going to also work to raise blood pressure. So the result in all of that is increasing glomerular pressure and GFR, so increasing your filtration rate in your kidney. All right, now the effects of ADH are to increase water permeability in the distal convoluted tubule and collecting duct. So water is reabsorbed from the tubular fluid back into the blood, and that leads to you retaining water instead of releasing it in your urine. It causes you to urinate a smaller volume of concentrated urine and hold most of the water in your blood and your body fluids. It also stimulates thirst, which leads you to drink more water. Now, aldosterone, the key effects of aldosterone are also along the DCT and collecting duct, and aldosterone works to cause you to reabsorb sodium from the urine into the blood, and that will raise sodium levels in the blood, which water is going to follow sodium, so that will cause water to follow the sodium so that you retain more water. And then another thing aldosterone does is cause you to secrete potassium, which reduces the potassium levels in your blood so that more potassium is lost in your urine. Now, ANP is produced by the heart, in the atrium of the heart. The key effect of ANP is to lower the blood volume and blood pressure by inactivating the renin-angiotensin-aldosterone system. So basically, if we go back to all four of these hormones, okay, angiotensin 2, ADH, and aldosterone, what do? They all three work to raise blood pressure and raise GFR. ANP works the opposite of these three. ANP works to lower blood pressure and lower GFR. Okay, so ANP is going to inactivate all those other hormones, renin, angiotensin, aldosterone. It's going to inhibit the secretion of renin, aldosterone, and ADH, and it's going to decrease the rate of sodium reabsorption in the DCT, and that will decrease the GFR. Now, sympathetic activation in the kidneys, when the sympathetic nervous system is activated, remember that happens in times of stress, when you are in a fight or flight response, fight or flight mode. That's going to act to decrease GFR. Your kidneys are not going to be, you don't want to be having active kidneys and active urinary system while you are, running away from someone who's trying to kill you. I don't know, anything that would cause you to, for your sympathetic nervous system to be active, in a crisis. There you go. I was looking for the word. In a crisis, you don't want your urinary system to be active. You want it to slow down so blood will flow more to your brain and your muscles so you can think and move fast. So your GFR is decreased due to sympathetic activation. Now, moving on, totally different subject, kidney stones, which are also called calculi, are solid substances made of calcium deposits, magnesium salts, or crystals of uric acid. They can form within the kidney, the ureter, or the urinary bladder. And kidney stones are very, very painful. They result in a painful condition called nephrolithiasis. They will obstruct the flow of urine, make it hard to urinate, and they may reduce or prevent filtration. And this is just showing you a picture of where the bladder is in a male, where it is in a female, the urinary bladder. And of course, it's more compressed by the uterus in a female, and that's why, especially once a woman has had a baby or two, maybe they have a problem with a little incontinence. And then this is a picture of the urinary bladder. This is a urinary bladder in a male because you can see the prostate gland here, which I guess that picture is just to show you like how when a man gets older and his prostate gland causes him problems, then that can constrict the urethra and cause him to not be able to urinate as easily. As far as the internal anatomy of the bladder, the base of the bladder has a triangular area called the trigone, and that is formed by the two ureteral openings, or openings to the openings to the urethra and the urethral entrance. So I'll show you. The trigone is here. You have the ureteral orifices, and what this is where the ureters enter the bladder. The ureters coming from the kidney, coming behind the bladder, and both of them enter here, okay? And then the formation of the opening to the urethra. So all of that forms a triangle. It's called the trigone. And the bladder wall contains layers of smooth muscle called the detrusor muscle. Contraction of that muscle expels the contents of the bladder into the urethra. The urethra in males is much longer, and in females it's much shorter. And I think everybody knows that. The urination is also called micturition. And voluntary control of urination depends on your ability to control the detrusor muscle. All right, now we're going to move on and talk about, again, something totally different. I'm going to skip some of that information, but we are going to talk about electrolyte balance and acid-base balance because it's important, particularly when it comes to kidney disease and diabetes. Electrolyte balance is important because the gain or loss of electrolytes, and electrolytes, remember, are the charged substances like sodium and potassium and chloride ions. But the gain or loss of electrolytes results in the gain or loss in water. And the concentration of individual electrolytes affects cell functions. For example, sodium and potassium, as you know, the levels of sodium and potassium inside and outside our cells function in maintaining the resting membrane potential across like our nerve cells and our muscle cells so that they're able to carry out contractions and action potentials and contractions and conduct electricity, that kind of thing. The most common electrolyte balance problems is caused by the imbalance between sodium gains and losses. And potassium imbalances are less common, but they're much more dangerous. So sodium balance, for sodium balance, sodium absorption from the digestive tract and excretion by the kidneys. So sodium is balanced by being absorbed across the walls of the digestive tract and then excreted by the kidneys. And sodium balance is regulated by aldosterone and ANP. Remember, aldosterone increases sodium reabsorption so that it will also increase water reabsorption. ANP is opposite. It decreases sodium reabsorption so that it will decrease water reabsorption. Remember this, water follows salt. So whatever happens with sodium, water is going to follow it. Increase in sodium increases blood volume, which increases blood pressure. And the same, if you have a decrease in sodium, that will decrease your blood volume and decrease your blood pressure. For potassium, 98% of the body's potassium is in intracellular fluid inside the cell. 98% of the body's potassium is inside of our cells. So we should always have a low potassium concentration outside the cells in the extracellular fluid. The balance, to keep potassium in balance, there's a balance between absorption in the digestive tract, absorption across the walls of the digestive tract into the blood, and excretion by the kidneys, same as for sodium. And the rate of loss is affected by aldosterone. Aldosterone increases potassium loss from kidneys. Problems with potassium balance are less common than problems with sodium, but they're much more dangerous. If you've ever had low potassium, you've probably noticed that as muscle cramps. Okay, how would eating a meal high in salt content affect the amount of fluid in the intracellular fluid compartment? Well, in the intracellular fluid compartment, well, if you ended up with too much salt, you would have too much water because water follows salt. I don't think it's more complicated than that. I think that's all it means, is that it would cause you to retain water. What effect would being in the desert without water for a day have on the osmotic concentration of your blood plasma? Well, you would get dehydrated, and that would cause your body to hold on to all the salt and water that it could. So basically that would be it. Okay, so I guess we're going to stop here, and we'll talk about acid-base balance in the next recording.